renal denervation, of which I had the chance to lecture briefly in the fellows course just the other day, and again in last year's course. So we give you the update every year, and this year we do have some updates to come. First of all, let's just all understand why this is important and why we care. Because we talk about this stenosis, the other stenosis. There is no stenosis in renal denervation. So all we knew about high grade this, high grade that doesn't really apply. But look at this incredible statistic. For every 2 millimeter of mercury decrease in mean arterial blood pressure at the population basis, you have a staggering 10% reduction in risk of stroke, mortality, or related hard endpoints. So, and then you think about all the other things we discussed the rest of the conference, and what is the benefit? The benefit doesn't come anywhere near that. We're talking about maybe there's a difference in quality of life, maybe there's a difference in, I don't know what, maybe the difference in ultrasound-based repeat imaging or some things like that, and all of those make sense. But God, do they really approach this level of benefit on the population basis? Definitely not. That's why hypertension is very important in any population studied anywhere. Then what is happening with the renal nerves and the center and the renal nerves and the sympathetic nervous system is something we always knew. We just didn't really know how to go about it therapeutically. There's a lot of communication between the CPU of the body, which is the brain, and the thermostat of the blood pressure, which is the somewhere in the kidney. Okay, pretty much when you have the thermostat in the house for the temperature, well, it's not exactly where the boiler is that kind of makes the heat, but it does communicate with the boiler up and down. And you know, those cables pretty much are representative of the connections the brain has with the kidney and other organs. And ultimately, if the thermostat in the house goes crazy, you really have to just put it off and figure out other ways. Otherwise, the situation is not going to be good. So pretty much the same thing we try to see if we detect that somehow the thermostat of the blood pressure, the kidney, goes crazy. Maybe we have to figure out by interrupting those connections, and somehow maybe we stopped this erroneous messaging that drives hypertension, whereas it shouldn't. So this is how the sympathetic denervation goes through all the organs. Let's just remember that from anatomy. I just put it schematically so you know that. It follows the arteries. Wherever the arteries go, that's where they kind of ride on top of the arteries and go towards the different organs. So in the renal vascular bed, the nerves are kind of hugging the renal arterial wall on the outside. That's where they are. So then we were in a catheter inside the lumen, and you can see the lumen is at the top left corner. Then you have the vessel wall, all 3 layers. The nerves have nothing to do with those layers. So but they're on top of the adventitia. So you need something that is not going to really transverse all these nerves, all this arterial wall. You just need something that's going to somehow bypass it and land in the outside of the adventitia. That's a goal. That's pretty tricky. You don't want to go through and through. You don't want to create a hole. You know, you don't need something like a knife, let's say, but you need something more like a missile that kind of lands from on top and then lands, boom, on top of 4 or 5 millimeters, 3 millimeters outside the spot that you're launching it. And we're able to do that by having some kind of energy that doesn't exactly go perpendicularly, but goes from different directions that kind of converges at the 3 to 5 millimeter depth where the renal the renal nerves are. So that's a whole trick about it, and that's why it hadn't been configured earlier, because it's just not the simplest thing. If you burn the artery, you're just going to thrombose the artery. So up front, this concern also was something of an issue that we had to clarify as far as the safety of these procedures. So that's where we are throughout the renal denervation. The original study, the Symplicity Hypertension 1, was a small study and said, you know what, hey, that's feasible. And, you know, it may have a potential. And then we had a bigger study, the Hypertension 2, and then some other registries along the side that primarily address the fact, is it safe or not? Are all these arteries going to thrombose where you touched it or not? Then you had Symplicity Hypertension 3 that had a sham control and that was a little bit of a surprise. First of all, and that we cannot understate that, it definitively showed that is for sure very safe. Because now we're over to 800 patients, and there was a lot of safety. And now, after so many years of follow-up and imaging follow-up, we can definitely say that wherever those arteries were intervened upon, there is no safety signal, there is no issue locally, there's no stenosis in those spots, the GFR hasn't been affected. So all the safety concerns have been, I would say, resolved. Unfortunately, it seemed like the sham intervention, there was a lot of effects with these patients. The sham intervention seemed to have induced a lot of reduction in mean blood pressure, and the anticipated benefit in blood pressure was not as big, and therefore it was ended up being not statistically significant. And this device has not been approved by the FDA, although it is approved in Europe. And I'm going to show you some results of the Symplicity registry with some areas outside the United States. And then we had some other studies that I'm going to relay right now and indicate to you that also we have some other types of energy ever since. The whole system was kind of, I would say, reboot and reconfigured after the Symplicity Hypertension 3. So first of all, it was said, okay, well, maybe the lower efficacy was based to the fact that maybe it was a radiofrequency ablation. How about if we have ultrasound-based ablation? And we have some studies to show you about that. Some pilot mode flavor studies. And others also investigated alcohol or even chemotherapeutics infusions with some needles through the vessel wall. I'm not going to show you much of that because it's really at the rudimentary stage, or they did not work that well initially and are currently reconfigured. We're going to address that maybe at a larger conference later on. So something that happened, though, ever since was that the catheter got better. So this is the same type of energy, radiofrequency, and you can see now the catheter has been configured that once you enter it over the wire, by the way, the initial catheter was not over the wire. You had to manipulate it empirically, and you have to touch every single point individually. Over here, you advanced over the wire. Once you remove the wire, the catheter assumes this circular configuration, spiral configuration, I would say. So it sort of hugs the vessel wall in multiple spots, and you have all these electrodes that through a panel on the outside, you can choose which ones to activate and which ones maybe to not activate because you feel that maybe they're in the side branch or whatever else. So therefore, you have the capacity to give at the same time the energy. So that saves a lot of time. And you don't have to keep repositioning back and forth the catheter into different areas. So made the procedure simpler, it made the procedure more predictable, it made the procedure safer, it made the procedure even more effective because you also were hugging now the catheter naturally. You don't have to kind of keep it, try to keep it in contact for the time of the ablation. The other thing that happened was that let's try to be even more careful about the population. And, you know, the kind of maybe a little relaxed aspect of Symplicity, Hypertension 3, that if you have high blood pressure, well, let's just kind of, you know, if you repeat it again a couple of weeks later, you know, anyhow, get in. Perhaps there were a lot of people that were motivated to not take drugs and they didn't say so. They were sort of fake it, in all honesty. And, you know, people there, you know, or maybe people that were non-compliant with a diet. Just because I like to eat salty food. And therefore, maybe those were practical reasons that should happen, but in a real world study, maybe they didn't happen. So now in Spyral, we were, I would say, a little bit more straightforward and say, you know what, there is a population that either cannot or will not or have side effects to medications and don't take medicines. And let's study these people separately. So we're upfront with these patients. So let's say if those patients were motivated to go in the study, they had to fake it before, whereas now they can just be in a proper Spyral off-med trial. And again, they have to go through a couple of visits in order to make sure that they're compliant, they can wear the ambulatory blood pressure monitoring, and, you know, they're kind of reliable patient. I must say those steps still exclude a lot of patients. Probably 80% of the patients end up being excluded from consideration, usually because themselves they didn't want to go through. So in the end of the day, many people still don't take their own problem seriously. and they don't want to follow up, not follow all the instructions carefully, and therefore they were deemed by the FDA fall-throughs of the procedure, and therefore we could not demonstrate that 8 out of 10 patients were compliant, like to show up, to give your blood pressure monitoring back, all these very simple things. I would say frustrating for the investigators because they weren't strictly medical reasons, but very practical reasons. Anyhow, we go to sham control, we go to a 3-month evaluation period. I'm going to show you the data, and then they could have crossover and whatever other things we follow them for safety further down the line. Those have worked very well, and most importantly, it showed that it met the criteria. Very significant reduction. Number of patients, not very high, 300 patients, about 150 per group, not the biggest study. Again, I would say kind of an extended pilot study, a big study, but not a definitive study, but a very well-conducted study with a lot of faith that the results can be reproduced in patients who met the criteria and also met the compliance verification criteria. You cannot go offer denervation to people that take it lightly, that we have doubts if they follow high salt diet. We have doubts if they take any medicines, if they show up, or they're in general unreliable patients. Those are not good patients for renal denervation. And then we went to a non-med study, now talking about a more classic situation, multiple meds, again through a lot of qualification to make sure the patient do take their meds. They're not just medical record meds that patients don't take. So compliance had to be verified a lot in this study. It was highlighted as a potential reason for failure of Symplicity. Therefore, we went through a lot to figure out that this was actually the fact. And indeed, at the 6-month result, again, pilot favored results, flavor results, as you can see, 80 patients, highly significant results. And I'm going to tell you later, we're going to have follow-up results at TCT this year in a few weeks. Let's move on to some other type of energy. Again, all the studies today, pilot flavor studies. None of those are, you see again, N equal 146. We can talk about them because they're out there. Don't think that we have, devices ready to use yet. So this study, they use the ultrasound. The balloon that you can see here, ultrasonic heating, water cooling, thermal profile that you can see over there. Anyhow, long story short, the similar flavor, renal denervation versus sham in patients who had the antihypertension medication wash out, essentially no medications in the control group, and see how that goes. Highly significant result, very promising, this device. Let's see how things go. 6 months, again, follow-up, very good results in essence. Then we had a 3-arm study. A radio sound hypertension, 120-patient pilot study, resistant hypertension patients. Now, the other one was a little bit off med, as I said before. Radio sound, and now we had one of the groups were radio frequency in the main arteries. The second group was radio frequency in the main and side branches, a lot of radio frequency. And the other one is the ultrasonic only in the main artery. Just to compare now, everybody gets denervation, but what kind of denervation you get? Very interesting results. And overall, it showed that, as you can see, the flavor is that the ultrasound seemed to be a little bit more blood pressure reduction in both ways. But again, the others were also good. Clearly, something we knew from Symplicity was verified also here. If you do the denervation only in the main artery, that doesn't work as well that if you go and do radiofrequency ablation in the main as well as the main branches. So again, it showed that in the denervation of the radiofrequency ablation, you really have to go a little bit into the branches, at least the main branches, and do radiofrequency there. Talking about now, I promised to show you some data of, of course, in the United States, we have all this series of pilot studies and here and there. But in other countries of the world, in Europe, in Asia, in South America, in Canada, in Australia, they do have the catheter, the Symplicity catheter available. and even the Spyral catheter available now. And nearly 3,000 patients have a median follow-up of 2.5 years, and they have been treated for clinical reasons and are part of this global, I would say, registry. Why am I showing you that? I'm not going to show you for efficacy. There's no control here. And in general, the patients might have been, who knows exactly what is, but clinically referred by the doctors for resistant hypertension. What I want to primarily show this to you is for safety, because I think everybody still has concerns, may have concerns. If you're not familiar with the device, is it really fine, or is it just, we may have delayed effects, delayed restenosis, delayed I don't know what. So in general, you have the better continuous reduction, and then you can see that is a pretty good in all patient groups, and you can see some of those over 65, less 55, diabetes, no diabetes, AFib, various things. Anyhow, pretty good efficacy, one can say. And most importantly, the safety was really shown very much and verified again in Symplicity. In a couple of more final slides, the ultrasound renal denervation radiant hypertension, the RADIANCE-HTN trio trial, which is essentially established in patient on meds, fixed dose, 3-drug combination. First, you have to stabilize that. Then you continue into renal denervation with the ultrasonic system versus the sham placebo. This was published this year. That's why I'm showing it in the end of my study. It kind of belongs with hypertension trials, but this is kind of definitely a 2021 update. A very important, again, a population basis at 2 months. I mean, the population results at 2 months with a reduction of, as you can see, I don't know, -8 and versus -3 in the sham. Not great, but pretty significant, one can say. Anyhow, we can see how this pans out in the new groups. I think we're still waiting for long-term randomized trial, is my one-line summary. There is a lot of hype between patient variability. We all wish we had some kind of an objective marker to find out who are the patients who might really benefit from this technique. We don't have yet. We also wish to have some kind of marker during the procedure. While we're doing the denervation, can we measure something? Can we see something that will immediately tell us we did a good job versus we need to do a little bit more? That we don't have again. We keep looking at that. And thank you for your attention. And as I said, we're going to have some important studies this year at TCT just in a couple of weeks. So look for that, and we'll discuss those in the updates 2022.
I want to ask you a question, Dr. Dangas. So in the registry, did they see any other beneficial effects apart from hypertension that compared to their so-called control cohort, reduced AFib, heart failure?
Yeah, well, this is another story that is evolving. There's many pilot studies that said, you know what, if we can, let's talk about first of all where they stem from. It's like if we can modify sympathetic nervous system, well, maybe the hypertension is only one of the positive effects. How about if we can modify pulmonary hypertension? How about if we can affect cardiovascular issues related with obstructive sleep apnea? And all those had some pilot studies somewhere in the world that were encouraging. And sometimes this has been accomplished by the denervation and the renal artery, sometimes denervation in the pulmonary arteries, sometimes ways to attack the sympathetic ganglia. So there is a lot of activity around there. So in the main studies, the population were pretty much hypertensives, so not necessarily had any other conditions. So we don't have any sub-study to indicate that, you know, in the Symplicity, X and Y happened in hypertension, and also heart failure was reduced. Most of those patients did not have, we didn't have this much of sub-studies, I would say. And we could not due to the patient mix. But I would say stay tuned about what we may see after denervation is approved, and it may be approved next year based on these results. And then we're going to start seeing radio frequency versus ultrasound And by the way, there's also external beam ultrasound somewhere in the mix as well coming around, even a simpler way to do it without no procedure, just on the outside. And after you gravitate on which may be a more optimal technique, then maybe those techniques then migrate and reopen those chapters of denervation of some areas for pulmonary hypertension, denervation of some areas in patients for obstructive sleep apnea, in general under the umbrella of sympathetic system modulation. And of course, one can say sympathetic system affects everything. We may start having a new chapter of cardiovascular medicine in association with those things. And what I have to say, yeah, sure, that's encouraging. And clearly, we're going to have many steps to go in this direction. Very, many exciting steps, though. I think there's nothing much we do for those conditions, and the absence of things to do, even from medical point of view. Let's say they found the same thing for heart failure with preserved ejection fraction. And things that are puzzling us, things are many problems. We can perhaps find this non-medical, non-medication related option that could be exciting. From that point of view, I think that's the main driver here. We have something exciting that seems safe. Well, let's experiment with it.
Wonderful.
I have two questions, Dr. Dangas. So the catheter that you use, and you mentioned it specifically tailored for the nerves. How does it work, and how can we be sure that it's actually worked and it didn't affect the arteries? And I think you mentioned Symplicity hypertension off medication. I thought this was for resistant hypertension. So did they assess it without patient on medication, with patient without medication? Yeah. So
great. Let's start with the last question. Our friend here did not understand very well the fact that there are two populations, and that's actually new. Let's forget about denervation for a moment. Let's make it simple. Let's say a new medication comes out and says, you know what, we're gonna do a study. Our medication improves blood pressure. How do they go about to get an FDA approval for high blood pressure reduction? If there are already, I don't know, another 100 medications that reduce blood pressure, there must be a way. They're not going to go and say, you know what, do head-to-heads. Not really. So there is a pathway that they go and experiment in patients who have contraindications to many medications. There are not that many patients, but there are patients who have side effects, and they cannot take medications. And then they give their pill and see if this new pill may help. And there is a stringent protocol that you can allow that for few months. You cannot do that and give nothing for years and years. But this exact protocol was replicated with a denervation device. So there were some patients, maybe there are minimal doses because they could not titrate them up and they had poor results. So they took them off for a couple of weeks, 2 weeks washout. And then they qualify for another 2 weeks, and they have a 3 months after the treatment. So within 4 months, FDA gave them to do whatever they have to do, and then patients will be back to be treated clinically. And therefore, they try to get essentially the device to be tested the same way any new antihypertensive drug could be tested to achieve an indication, very broad indication, for treatment of hypertension. So that targets that. The other one is a resistant hypertension, was documented again with many steps in order to make sure patients are compliant. A lot of problems in the clinical trials in hypertension in general is that we're not sure. Nobody can be sure. If patient comes in and out of the office, checks a list of medication, you take some meds, I take my meds, and then go home, they don't take their meds. And that is you have to somehow police that, and police that to a very high degree. Or similar thing. Also, I never eat salt. They go home, they eat all sorts of sausage and bacon 3 times a day. No salt. So people, it's a behavior issues that, and those have to be ironed out and be out of the study. I don't know how you treat that. This remains problem in hypertension, but it cannot be mixed and mess up the results of the study. That's what I would say.
Thank you. Perfect. Thank you.